Hi,
Hi,
are you Sonia?
I am. How are you?
Well, how are you?
Good, good, good. So, just so you know, it will probably, wait, is this you also joining?
No, no, it shouldn't be.
Okay, you're in the waiting room also. That's so strange. Okay.
Oh,
Um, hmm. So we'll start with the case, and we'll probably just have the case. Dr. Cantor might ask if anyone else wants to share anything or say anything, but just to go through the setup, so we'll have our introductory slides and then like just like general housekeeping, and then Dr. Cantor will pass it over to you and just do a brief introduction of you. Um, and you can present your case. She'll summarize it and then ask people if they have any suggestions, questions, or whatever, and discussion.
okay.
So
Okay.
that's and I have your case, so I don't have to worry about like checking the controls or anything. Your sound is working perfectly. So I'll share your screen when it's time. I'll share the screen that has your case information.
Let me- Wanted to make sure I also, Sonia, would she be able to just practice sharing the
Oh, do you?
presentation?
Okay, yeah, I have the slide.
Just
I
to
didn't.
make, oh,
Yeah.
well, she just wanted to make sure everything was in the right view and everything.
Okay, let me, so are you going to share or do you want me to share it?
Um, I can try to share it. Let me try to share it real. Oh, I see what you're saying. If you want to share it, then try to share it and let me make sure that the right screen, because I have two screens and it was like a weird issue one time where I was trying
Okay, yeah.
to.
Let me do that real quick because I had just pulled it up so I could have it ready. Now, if I can find it in all my open tabs. Okay, so this is it, right?
Oh, well, this, but then here is, oh, you know what? Here, I can send you, you have the form. She has
Did you want to?
actual slides.
Oh, okay. Okay. Well, I mean, I've made it so you can share. So if you wanted to share your slides or if you want, however you want to do it, whatever's easiest for you is fine with me.
I will send it to you just in case there's an issue, and then I
Okay.
will try to share. Um,
That is not a problem. So I've made it so that the host can share, I mean, so that participants can share. So you should, so if you want to test that out to make sure it's working okay, then you should be able to do that.
okay, yes, I will do that. And that's it.
Okay.
And I'll send that to you just in case there's an issue.
Yeah, no problem. Don't send reminder messages.
Oh, no, is anything popping? Oh, okay. Can you see it?
Oh, hold on. Let me go back to that screen. I was
Okay,
looking. Yeah, I can see it. Great. Perfect.
okay. Then so I need to take it off and then I'll come back to it, right?
Yes. Yeah, because I'll do the introductory slides and then like I said, then we'll move over to the case.
Mm,
And it's just general housekeeping, reminding people to like how they can do the CME information and so forth.
okay,
Okay. So I will let people in from the waiting room. We have four waiting. So I'll go ahead and let them in now.
okay.
Oh, it's so weird. Your name pops up. So maybe you shared it with someone. I don't know. We'll see.
Hey, Sonia.
Hey Priscilla, how are you?
I'm good. How are you doing?
I'm good.
Good. How's the weather down there?
Hot.
I know, right? Same here in South Carolina.
I was talking to someone in Virginia earlier today that said that the heat index there is like 114 degrees. I
Oh
was like,
God, I think it's
oh,
100 here.
horrible.
And we have camp this week for our clinic.
Yeah.
It's for all of our kids that come to clinic, and it's going to be in the 90s here the whole week, and it's just been so hot.
So I'm sure you have water stations all over the place for
Oh,
them.
definitely.
Ugh.
Definitely. And like today was staff day, so all of us got to attend camp with the kids today, and it was just hot from the start, right at 8 o'clock in the morning. It's just scorching.
Oh gosh. Well, drink plenty of water and be careful out there.
Oh yeah, definitely. Is it just us today?
No, it's we've got people that are still trickling in.
Yeah, I got a few more coming. Who's presenting our
Oh, hey,
case?
Dr. Cantor.
Sarah Harris.
Hi, Dr. Cantor. Hi.
Well, let's give it one more minute and then we can get started. All right, let's get started, Sonia. If you want to put up our opening statements real quick and then we'll let Sarah get started.
Alrighty. So we have our accreditation and EOE statements. We don't have any disclosures for today. And then if you, for CME credit, you can scan the QR code or click on the link that I will put in the chat box. And we have just a couple of, well, a few announcements actually. So we have the upcoming support echoes. So we have coming up on Tuesday, we have in 8 in the morning a.m. The UAB echo, as well as the other ones you see here on July 17th and again August 5th. And then we have the NASAC conference. And then the Tate Holbrook sickle cell update from ECU. All right, and that's it.
All right, and we don't have a didactic today, so we'll just do our case. So Sarah, I'm turning it over to you.
Thank you. Can everyone see this?
Not yet.
Okay. Should be.
Now you're good.
All right, perfect. Good evening, everyone. Thank you for having me. My name is Sarah Harris, and I am an APP fellow working here at Norton Cancer Institute in Louisville, Kentucky, here in our adult outpatient sickle cell program. And I am presenting on behalf, I've been working with Erin Samine down here, so I'll be presenting for us. So this is a case study presentation today. So the case study involves a 45-year-old Liberian male with sickle cell beta thal plus with frequent pain crisis. Has a other medical history of thrombocytopenia, splenic infarcts, had acute chest back in 2019. He's got hypertension, pulmonary hypertension confirmed via heart cath in January of 2023. He's got OSA, chronic pain, type 2 diabetes, past history of DVT, and depression anxiety. This patient was seen in our outpatient clinic. His most current and recent labs were done on 6/9/25. His hemoglobin that day was really close to his baseline. He was 12.1. He usually has a baseline between 10 and 12. White count was 2.6. His ANC that day was 1250. NCVs, as you can see, are 73. You can see his retics and his hemoglobin electrophoresis with a nice percentage of 60%. Creatinine and billy were normal, and his urine tox was appropriate on 5/29 for his narcotic use. His current medications listed, he's on amlodipine. He is getting baclofen, crizanlizumab monthly, duloxetine, folic acid, metformin, Percocet 10. He's getting 120 of those monthly, and then spironolactone. So treatment plan for him for his frequent pain crisis, he was initially prescribed hydroxyurea at 1,000 milligrams per day back in August of 2018 for recurrent pain crisis. He mostly remained on that dose up until December of 2023, where he was increased to 1,500 milligrams. During that time, his ANC was 2,200. His platelets were fine. They were 154. When he was followed up with about a month later, his ANC had decreased to 1,900. And so at that time, his hydroxyurea was continued at that same 1,500 milligram dose up until April of that year, when his ANC dropped to 800 at the 1,500 milligram dosage. So the hydroxyurea was held, and he was ultimately held up until he was restarted in August that year. And he was restarted at 1,000 milligrams daily during an inpatient admission when his ANC had recovered to 2,000. So after he was discharged from the hospital, he was followed up in clinic. And during that time on the 1,000 milligram daily, his ANC had dropped to 1,410. So he was held and restarted a couple of weeks later at the 500 milligram dosage per day. Further, he ended up having to increase due to his ANC dropping some as well. And so he was trialed on 500 milligrams of the hydroxyurea every other day in December of 2024. And then further decreased to 300 milligrams a day during when his ANC was 1,690 earlier this year in February, until he was ultimately discontinued when his ANC dropped to 1,270 back in March of this year. He is still receiving Dacfio or crizanlizumab. He was initiated last year in April and is receiving that monthly for decreasing pain crisis. And then he's also the Percocets for severe pain crisis. He's getting those per month as well. However, within the past year, he's had multiple hospital admissions for pain crisis. He's had 8 total admissions. So since the neutropenia has been an issue for him as far as tolerating the hydroxyurea, he has continued to deny fever, chills. He's had no recent or recurrent infections, and his vital signs have all been stable on his monthly Adakveo visits in clinic. We had the last time he was in clinic as well on 6/9, his vitamin B12 and folate were checked. Those were normal. He had an ANA that was done because he does have significant chronic pain, mostly joint type of pain. That was checked in January of 2024. He was negative. He had normal CRP and ESRs that were done in December of 2023. And then on 6/9, he also rechecked a hepatitis and HIV on him, and those were non-reactive as well. While he has had several inpatient hospital admissions, and he has been they prescribed methocarbamol for him off and on throughout those. And he had actually recently ask for a refill. However, we just have tried to go through his med list carefully and try to decrease as much as we could that could affect his white count. So just for the potential, we recommended he not take them at the carbamol as well. And that is why he's on the baclofen for pain, mostly back pain. And then we have continued to monitor his labs monthly with his Adecbios. His thrombocytopenia, he has a history of splenic infarcts. He did, whenever he had his hospital admission, in April, he had a CT scan that just showed he had some splenic lesions. And so after reviewing that with him here in clinic, um, we recommended that, especially with his lower platelet count, recommended him have an ultrasound of his spleen. And so he had that done after leaving the hospital, and he had a normal sized spleen with none of the lesions were identified on there as well. So for chronic pain for him, he's had a long-standing history of having joint pain, even at his initiation of his hydroxyurea. So it was but he was also having pain crisis as well. So we have tried to focus also on trying to help with his chronic pain. He does have bilateral knee pain, low back, and bilateral hip pain. Um, he had a X-ray of his hips earlier this year that did not show abnormalities for that. We were just worried if he had AVN that was causing more pain. He did have a right knee X-ray, which he complains of more right knee pain than left knee pain. That was done in August of last year. They weren't overly concerned with anything other than maybe some arthritis, but he did have preserved joint space. He also had a lumbar spine X-ray in June of 2023 that was normal. We did recommend that he try some physical therapy as well. And so he tried physical therapy last year and went to a couple of visits, but complained of worsened pain after starting physical therapy. So he has not been back. So for his chronic pain, we were encouraging him to only take his Percocet for severe pain crisis. And he's been taking just Tylenol as needed, his baclofen, and then he is already taking duloxetine for depression, anxiety, but we also had him on 60 milligrams to see if that would help with some of his pain, especially knee pain. So for him, the questions that we had for him, the patient being concerned as well, since he has been off of his hydroxyurea since March.
He needs
So,
a bone marrow.
okay, okay. That was what I was wondering about further workup. So,
Yeah, I
do
don't know why we don't do these we wait a long time. I just had a patient with AML. And we waited a long time, not that it would have made a difference for her, but we need to do bone marrows when people aren't responding the way they should.
okay, after being taken off of the hydroxyurea, I guess, is it worth repeating an ANA on him, like doing a
No, do a bone marrow.
Okay. Um, and then, so after stopping, what is the usual time? I mean, how long do we usually give people time to recover?
A
If you
couple,
actually go
yeah,
on, Jay.
a couple of weeks from hydroxyurea. I mean, if someone has parvovirus and their spleen gets big, it might be different. But I agree with Julie. I have been burnt not getting bone marrow soon enough, and now I get bone marrow sooner. And occasionally if it's isolated reticulocytopenia, we've diagnosed a couple people with iron deficiency anemia based on bone marrow where we didn't think that they had it based on their labs. But when you start to see thrombocytopenia and neutropenia in a patient that didn't have it before, when they can't tolerate any hydroxyurea when they're at 1500, this person will have MDS or something going on in his bone marrow. Probably not autoimmune, probably a heme malignancy.
Yeah,
He's well above my,
agree.
Pretest probability, probably above 50% now. And really, if you get up to about 5%, you should be doing a bone marrow. So I think that we give people with sickle cell disease sometimes a little bit too much time.
Okay. Okay.
I do. I think that there is far more bone marrow dyscrasias than we are recognizing because Well, because we don't want to, but also because we have hydroxyurea in the mix. And so, my most recent patient was interesting in that she had always been a phenomenal hydroxyurea responder, young, she was in her late 20s and she suddenly wasn't tolerating it as well. And I thought she had parvo and she may have, and then we restarted her and she would slowly drop again. And it was only reticulocytopenia initially. Interestingly, when I held her hydria completely, she got pancytopenic. Um, that's when we figured out that she had AML, and the hydria was actually treating the AML, which is why she got worse when we stopped it. But I do think, as JJ suggested, we need to be quicker to be looking for bone marrow abnormalities.
Okay, okay. And then we were thinking for him, so he's still receiving his Adakveo monthly, for
So
prevention
is
of.
it helping him?
It's questionable. It's definitely questionable. We know that he does have a lot of chronic pain, but I mean, I don't know how much it's been helpful. We were trying to,
So what was he like the year before you started it? You said you started in April 24. How many times was he admitted the year prior?
was it the same month? Around the same month? It's about the same, yeah. Okay. Yeah, I'm sorry, Aaron's here as well, so around the same amount.
So probably not. So usually what I have done, just, and this is something that I recommend to everyone,
Okay.
no matter what you're starting, but we really need to make sure we have a set time frame for assessment. So you start something 6 months later, you really need to say, is this working? And talk to your patient about it, right? Is this
Mhm.
helping you? Do you feel better? Do you feel worse? Have a shared decision discussion.
Okay. That's definitely helpful. We wanted to see if with him having pulmonary hypertension as well as the pain crisis, about starting red cell exchange for him. Although with automated being better, we're shared with pediatrics group. And so the comfort level sometimes with patients that are a lot older and those that do have some significant comorbidities is different. We're trying to um, work that out, but we wanted to see if we can do partial, if that's an option for him. But we're also concerned with his hemoglobin being between maybe like 10 and 12. And if that could help, what would be the usual threshold for we don't want it to get too high. So
Well, when you're
helpful.
exchanging somebody, you're going to equal exchange them. So you don't need to worry about him being high, right? If you start at 12, you should end at 12.
Yeah.
So I wouldn't worry as much about that. Going back to his pulmonary hypertension, how severe is it? What's his TR jet? Has he had a right heart cath? What did it show?
Did have a right heart cath, and he does still follow pulmonology for this as well. The pulmonologist, he last saw them back in April, and he's been on amlodipine, and he felt that the amlodipine maybe could have possibly helped with that, but he has had subsequent echoes that are improved. So he continues to follow them, but yeah, they're seeing him for that as well as his sleep apnea.
So
And
amlodipine won't treat pulmonary hypertension. That's for systemic hypertension.
okay.
So it'd be helpful to see what that right heart cath, in other words, does he really have pulmonary hypertension is the question. Because if the diagnosis was made only once on an echo when he was in the hospital, like
Mhm.
sick, that's not always reliable. You have to do one at baseline and a right heart cath at baseline.
Yes. I don't think that he's repeated the right heart cath, but he had the right heart cath back in January of 2023.
So it's
So
been a minute.
yes, okay. And I honestly don't know what it didn't look like that they had planned on doing another one like coming up soon, but he has had subsequent echoes.
So maybe
So
talk to the pulmonologist and see if they think he actually has pulmonary hypertension.
okay.
What is he chronically hypoxic? Does he wear his CPAP?
He has recently had another sleep study and he had another machine. I think he got one a month ago or another one because he did have one before that wasn't helpful. So they did change some of the settings for him to see if that would help. So he should have picked that up last month.
it wasn't
sleep apnea.
helpful.
For the CPAP settings, they changed the settings on it.
Okay, I just not quite heard it said that way, that CPAP didn't work. Because then I'm not sure that it's obstructive sleep apnea, and does he just have nocturnal hypoxia?
Okay, well, good point.
So I think there's a couple of things you can optimize here. I'd really look into Adakveo. I think it's works really well in about 30% of people and really doesn't work in about 30% of people. And
Okay.
and in those people, some are worse. So I would definitely not assume that it's working.
Okay.
I agree. I mean, I think before I would worry about exchanges, I would get a bone marrow because I'm very worried about his bone marrow and how much of that pain is bone marrow pain.
Hmm.
And Percocet, 120 a month is not good for anyone.
Yeah.
You're treating chronic pain and you're causing more hyperalgesia without a doubt.
Yeah.
And so this is someone that I would say we can't keep doing this. We have to change because this isn't helping you if you're being admitted 8 times a year. So, and I'm not clear how much of this pain is actually caused by his sickle cell disease.
Yeah. Good point.
And these are hard. These are always really hard cases, but I think you have a lot of places that you can start. So I wouldn't, again, I definitely think you need to start with a bone marrow. I think that that's going to be your most important question. Let's hope it's 100% normal and he had some virus that just depleted him. And then
Okay.
you can come back to thinking about these other things.
And
Okay.
obstructive sleep apnea can also drive some of the pulmonary hypertension and pain. So I
Mhm.
think that the optimization of treatment of his obstructive sleep apnea can make a difference as well. Can certainly be a contributor and a driver to disease severity.
Yes.
Absolutely.
Yeah, he's one that you have your hands full with.
But this is not uncommon, and we all see individuals like this all the time. And I just think, let's take his bone marrow out of it. Let's just assume his bone marrow is fine for the moment. In his case, when we start exchanges for someone like him, I actually don't often think that we're treating their disease. I think we're treating their behavior. And we're treating our own behavior because meaning that we start putting them on exchanges so that we can have a very good rationale to say, you do not need IV opioids. They are not helping you. We're treating chronic pain. And, bringing somebody in weekly for IV opioids, you're treating chronic pain, right? And so the same can be true with 120 Percocet a month. If you're getting, I have patients who get 120 pills a month, not very many anymore, but the only ones that I keep on that are the ones that never come into the hospital. Because some
Mhm.
people just don't get opiate hyperalgesia,
Yeah.
but most do. And I'd be curious to see how many of those are withdrawal episodes, how many of those times that he's actually just out of meds.
Right.
So I think you have a lot here you could kind of work with.
And then regarding the hemoglobin, if we're doing partial manual, we have a patient who's an SC patient and they have a higher base hemoglobin as well. So do we ever feel like that it's too high on a baseline that is going to cause more issues than anything being on partial? So him being between 10 and 12, but her being 13 to 14, like, do we ever have one where it's kind of just too high to even start partial manual?
No, because you're always going to take some off.
Okay.
The other thing is, at least the French will tell you, and they actually had a poster about this at EHA this year, in your person with hemoglobin 13 to 14. The French are firm believers in phlebotomy for people with SC disease specifically. I don't think this is true for S beta plus. I think we cause more pain in people with S beta plus by putting them on opioids. That's my general bias. But SC disease, they have some really good data that shows that phlebotomy plus hydroxyurea can be highly beneficial if done well.
Okay.
In fact, when I talk to my French colleagues and I talk about SC, they're like, why aren't they on phlebotomy? Kind of like, what's wrong with you? Because it is such their standard of care. It's something I think we haven't optimized here or, really embraced, but I think it's interesting and something to think about.
Okay. So phlebotomy is in only phlebotomy or phlebotomy and transfusion? Just phlebotomy? Okay, wow.
Yeah, I can send you the protocol that I translated from them.
Oh my gosh, that would be very helpful. Thank you.
We have a couple people that we've used. One who he has transportation issues, but he says he is much better when he was doing it. And I especially will use it in people with really severe retinopathy. Again, mostly anecdotal, but the data is interesting. It's encouraging.
Okay. Yeah, I would love to see that. Thank you. I think those are all the questions that I've had. So we'll consult with the rest of, with our attending and let him know as well, and we can move from there too.
Yeah, and definitely let us know. Let us know what his bone marrow shows. I worry a lot that we're missing things with bone marrows.
Okay.
I learned, right, that people got more anemic as they got older because of bone marrow burnout. Well, no one was ever doing a bone marrow to see if what was really wrong.
Yeah.
But we've had a couple of older SC patients with MDS. And as I mentioned, we just had a young woman with AML.
Okay.
Yes, I will send out the phlebotomy protocol to everybody.
Very helpful. Well, if there are no other answers, thank you so much, you guys. This is my first
That's
time.
a very good case, very hard. We all take care of these patients, and when I talk to them, I say, I got you into this mess. I'm the one who gave you all these pain medicines, and now I got to get you back off of them because I'm no longer helping you.
Yeah, absolutely. Okay. Well, I appreciate the opportunity to present. Thank you so much.
All right. As I said, we don't have a didactic today, so you guys are off the hook a little early, and we'll look forward to seeing you in 2 weeks.
Thank you.